Okay, hi everyone. My name is Dr. Kenneth Lim. I'm one of the other urology docs at Potomac Urology. Thank you so much for tuning into our webinar series. Uh, it's right at 5:30. We have a good amount of people here, so I'm going to get started. Um, and then there's a chat box for any questions. At any point in time, if you have questions up on the slide, you can enter your questions into this chat box so that at the end, you won't forget your questions and we can make sure we get all the concerned questions answered then. So I'm going to start sharing my screen now. This is our agenda for today. I'll introduce myself. We'll talk about the symptoms of BPH or benign prostatic hyperplasia, how we diagnose this disease process, and the treatment options available. And like I had mentioned earlier, uh, we'll make sure we make room to answer all your questions too. So my name is Dr. Kenneth Lim. I went to residency at Georgetown University Hospital, went to medical school at Virginia Commonwealth University, and did my undergraduate at University of Virginia. So I am very local to this area. My areas of interest include BPH, specifically aquablation, uh, doing robotic surgery using the Da Vinci platform, and kidney stones. So, what is the prostate? The prostate is a gland that plays an important role in male sexual function. During a man's life, starting at age 20, your prostate will continue growing. When you are 50, 60, 70s, that's when it'll grow enough to cause a problem. So in this diagram here, there's the bladder. And then when you're younger, this channel is wide open. But as you get older, as your prostate enlarges, it compresses this channel. It makes it more difficult to pee. BPH is not a prostate cancer. You can have a large prostate and not have cancer. You can have a large prostate and have cancer. They're unrelated issues. They just both happen to happen in the prostates. And the cause of BPH really is unknown. So the analogy we like to make is the prostate is like a donut. In the inner circle of the donut is your urethra, your prostatic urethra. And as you age, that hole gets smaller and smaller. And so the goals for therapy to treat enlarged prostates is to make that hole, that channel bigger. So when you do have BPH, how do you know? Well, eventually it's going to get a bit more difficult to pee. You know, your typical urinary habits will change. Uh, there are two categories of urinary symptoms. The first is the ability to hold urine. So when your prostate is blocking your bladder has to squeeze really hard, and it can do so by getting stronger, but uh, it's at the expense of becoming too overactive. So you can have a lot more urgency, so it's hard to hold your urine in. You can pee more frequently. And at nighttime, because of this higher level of overactivity, it'll wake you up to pee. And in some more extreme cases, the urgency can be so much that you may actually leak urine. The other side of urinary symptoms are mostly due to the plumbing issue of a prostate blocking. So you're going to be having to strain more to push urine out. The stream may be slower. You may have some burning or stinging to pee. You may not feel like you're completely emptying all the way. Instead of a continuous stream that you used to have, it may be stop, go, stop, go. And you know, this is all about quality of life. It's good that it's not life or death, but it doesn't mean that you should take it for granted. You know, I think a lot of my patients, they just slowly get used to these symptoms getting worse slowly and slowly, that they don't realize the decrement in quality of life that they've had. So, you know, this can lead to disrupted sleep, limited activities. You can't go enjoy your hard-earned retirement time because you're too concerned where the closest bathroom is. It can also affect sexual dysfunction. Having a large prostate may affect your ejaculation and even your erections. So, stages of BPH, I kind of hinted at this earlier. Early BPH, you have some constriction uh, as the compression gets more and more, your bladder has to compensate. Eventually, your bladder can only work so hard, and if BPH goes untreated, you can get to the point where you may not be able to empty your bladder at all and you're catheter dependent. And so the goals of treatment should be getting you treated when you're in stage one, in stage two of this disease process, because the sooner we intervene, the more of your bladder health we can preserve. If you wait until you're catheter dependent, yes, for sure, we can still treat you. We can unblock the prostate. However, the years and years of damage from the bladder squeezing so hard, that damage may be irreversible. So while your stream might be really strong after the procedure, you may be emptying your bladder well, the damage to your bladder causing symptoms like frequency, urgency, waking up at nighttime, those may be permanent. And so we want to make sure we protect that to begin with. So here's another picture illustrating what a healthy bladder looks like. Nice and smooth. As your bladder has to get stronger and bulkier to push urine through a blocked prostate, it gets, you can see the muscular fibers. And then even worse, you have like these hole appearing areas called diverticula. So in order to diagnose BPH, a lot of it is reviewing your symptoms. There may be a physical exam where we do a rectal exam to get a general idea of how big the prostate is. And then there are some peeing tests that we can do. And so we've had patients similar to John who, men don't want to be talking about their prostates, their peeing problems. They just want to be enjoying their beers. But if men talk more, they would realize this problem is very, very common among men. And so when you first see us, if you already have, you're going to get this IPSS symptom survey where it's asking you all these questions about your symptoms. This is an objective way that we can see how bad your symptoms are. The most important question of this whole survey is the bottom quality of life uh, questionnaire. Some people may have scores that are one and twos, but their quality of life may be horrible. That's reason to intervene. Other people, yeah, they may have scores of threes to fives, but if they're like, hey, it's not a problem, then sometimes we can be less aggressive. Again, this is very tailored to how patients are feeling. So, the IPSS score will give us your symptoms. We do a peeing test called a Eurocuff test. And this Eurocuff test, we put a condom onto your penis, like the picture. And as you pee, it measures how well the flow is coming out. As you're peeing, we have a cuff that will slowly inflate until it adds enough pressure that you aren't able to pee. The pressure at which it stops you from peeing is a surrogate measure for how high your bladder pressure uh, can get to squeeze urine out of your bladder. And this test is really good because it tells us more than just if you're peeing slow or fast. Because going back to my plumbing analogy, if you have a low flow, that could be because your prostate's blocking, or it could be because your bladder pump pressure is just not squeezing hard enough. And so when you're younger, the bottom right graph on the x-axis is your flow. So when you're younger, you're on the right side of the graph because your flow is really fast. And then on the y-axis is your bladder pressures. So when you don't have an obstructed prostate, you can get really good flow without your bladder working too hard. Once we get to stage one of BPH, where there's some sort of blockage, you're able to still maintain a good flow, albeit with higher bladder pressures. Eventually, though, if your bladder pressure stays this high, your flow will start slowing down because your prostate continues blocking. And despite a higher bladder pressure, you start having lower flow, urinary flow. Eventually, if your bladder pressure stays this high, it can crap out basically, and the flow also, the pressure and flow both go down. And at that point, we're concerned that you're getting close to being catheter dependent. The next part of the workup is to do a cystoscopy, which is a camera down your penis. So we do this in our clinic or our surgery center under nitrous for more comfort. We put numbing jelly down your penis. Our camera goes in. We're able to get this view right here to see if the prostate is open or if it's closed. Your prostate shapes vary. Sometimes it's just the side walls coming in. Sometimes it's the middle lobe that's present also. The shape of your prostate will determine what procedures may be better or worse for you, or may not be as helpful for you. And then while we're going inside your bladder, we can also see the bladder health. If you have that muscular looking bladder that looks overworked, then we can also see that. At the same visit, we'll be doing a transrectal ultrasound where instead of using my finger for a rectal exam, I'll place an ultrasound probe and take measurements of your prostate to get an accurate size. So in our practice, we offer about 10 different procedures to treat enlarged prostates. It's a very tailored approach. It's not only your size, shape, health of your bladder, but also the desires and goals of each patient. So you can go anywhere from just watching things, to doing medications, or going forward with surgery. And you don't necessarily have to fail medications to go to surgery. So, like I said, it's going to be a very tailored approach. Uh, some people care more about maintaining ejaculatory function. Some people don't want to be on medications for the rest of their lives. And some people, they're okay with just doing smaller, less invasive tune-up procedures that they may need every 5 years versus other people, they want to be one and done. They want to have a procedure that will last a little longer, even though it may mean a little bit higher chance of complications like bleeding and needing a catheter. So patients who would be great for watchful waiting, very mild symptoms. We can check Eurocuffs to make sure they'd be a good candidate for watchful waiting. But eventually, the prostate will continue growing. And like that saying where if you toss a frog into slowly boiling water, it won't jump out and it'll just die there. But if you toss a frog into immediately boiling water, it will jump out because it can't get used to how bad things get slowly. And so we want to make sure that instead of just tolerating your symptoms, that you actually address your symptoms. Medications. So this is for mild to moderate symptoms. These medications, there are two main classes, Flomax being the most popular, and then Proscar or finasteride being the other class of medications. And these medications can work. However, they only work when you take them. Like diabetes or blood pressure medications, when you stop taking them, you're not fixing the problem. And so, and eventually, because prostates continue growing, these medications can stop working after a certain time period. So, I think there's been a huge innovation boom in BPH treatment. Way back when it used to be the old roto-rooter that people used to do, and there was higher chance of incontinence, um, higher chances of erectile dysfunction, ejaculatory issues. But we're in this era of minimally invasive procedures, and in our practice, we offer all of these: the iTind, prostatic artery embolization, aquablation, urolift, Optilume, uh, holmium laser enucleation of the prostate. It used to be that if your prostate was so large, we would do a big abdominal surgery to remove it, but it's really unlikely now that we have to do an invasive procedure. Most of our procedures will just go through your penis and not make any new incisions. With this boom in innovation, it leaves patients in a position where they don't know exactly what to do. And so the first class of procedures are our minimally invasive ambulatory surgery center-based procedures. These are always same-day procedures. They are typically shorter, like anywhere from 5 to 30 minutes. These include the urolift, Optilume, iTind, and prostatic artery embolization. There's very little risk of sexual side effects like retrograde ejaculation or ED. However, the trade-off is it may not be as durable, may not last as long. It may only last 3 to 7 years, compared to the more durable procedures that could be 10 to 15 years plus. Um, then there's more minimally invasive surgical options like aquablation and holmium laser enucleation of the prostate. With aqua ablations, I would say this is the workhorse of our practice. We are the most advanced center in the country. We adopted the technology when it first came out in 2018, and we've done the most in the whole country. Uh, and aquablation, I'll elaborate more on this later. But basically, the chances of retrograde ejaculation are very low, about 10% risk where you may have ejaculatory issues afterwards. Basically, no risk of ED. Uh, Durability lasts about 15 years or more. The stated incontinence rates are less than 1%. And compared to the more minimally invasive procedures, this as a surgery, there's better improvement in urinary symptoms. We also offer holmium laser enucleation of the prostate. These are for much bigger glands. This is good for people who may be catheter dependent, and we're questioning how much function their bladder has. This procedure is the most definitive procedure in the sense that it can remove the most tissue. So you unobstruct someone completely. However, the downside is there's a slightly higher chance of incontinence at 3%, but the durability is lifetime. And then the kind of class of its own is maybe you can call it like super minimally invasive. In this procedure, prostate artery embolization, it is so minimally invasive that urologists don't even do this procedure. Our colleagues in interventional radiology are the ones that does that do this. Basically, it is a 30 to 45-minute procedure under light sedation, like a colonoscopy. They will access your groin, find the artery supplying your prostate, selectively decrease the blood flow to your prostate, and in about 4 to 8 weeks, that decrease in blood flow will shrink the prostate 30 to 50%. And even in our more elderly patients, 90-year-old patients, this is a safe procedure. This procedure has the quickest return to normal activity time, anywhere from days to a week. You may have some discomfort in your pelvis for a week or two, but overall, it is the safest procedure, less than 1% complication rate, and the benefit to risk ratio is probably the best. However, it has a 80 to 90% success rate, but that also means that it has a 10 to 20% failure rate. In ideal cases, this lasts for about 5 years, and there's good data showing that if you had good success the first time, you may benefit from doing a repeat PAE. The reason why it doesn't last as long is that eventually your blood vessels will continue to grow, regrow, and then your prostate will regrow. But this procedure, there's no catheter, there's no bleeding, uh, and so a lot of patients like this option. Afterwards, all you have is a bandage on your groin, and then you follow up with us afterwards around like the 4 month mark to see how your flow has improved, if your symptoms have improved. It You do not lose anything from doing this procedure. It doesn't preclude you from doing any of the other procedures. But if you do get benefit, then it saves you from doing a procedure through your penis. So the next procedure is the UroLift. This is an in-office procedure. It doesn't remove any tissue, but these internal permanent sutures are in place that basically just open up the prostate. So it makes it so you can the flow is stronger, nearly 100% preservation of sexual function. Uh, Often you don't even need a catheter after this unless we're concerned about uh, like more bleeding than typical. However, uh, if you have a median lobe, this may not be the best procedure for you. And if your prostate is too big, again, while we can do it, it may not have as good durability. When we do this procedure, it's typically with nitrous oxide laughing gas, quick onset, quick offset. We also use a numbing shot like at the dentist. It takes about 5 minutes to do. Typically, like I said, no catheter. You'll notice some blood in your urine afterwards that you just stay well hydrated and you just continue to monitor. You may have some pelvic pain for a little bit. You can get back to your normal activities as early as a week or two. And the symptoms, there's an initial period for 2 weeks where there's some residual swelling. So after that 2 weeks, that's when you start really noticing the difference, and improvements can occur all the way up to 3 months. And right now, the data is showing that it's definitely good for 5 years and even more in some patients. The next next procedure is iTind. This is also can be an in-office procedure. Again, these minimally invasive procedures, they're not removing any tissue. So this device is in your body for about 5 to 7 days. It basically stents open the prostate and adds enough pressure that something called pressure necrosis happens, where even after you remove it, it remodels a prostate to keep it open. And iTind is one of the newer procedures available. We are one of the first centers in the US to be offering it, and we are one of the 2 training sites in the US. So across the board, we have a lot of experience this relative to other practices. Optilume is our next procedure. This device, instead of having a stent or whatnot, you have something that goes into your penis. There's a balloon that will dilate and stretch open this area, and this balloon is coated with a drug called paclitaxel. And what it does is it prevents the prostate from healing and getting back to being small. So it ensures that the prostate stays open. There's no cutting, heating, burning, lasering, or any implants whatsoever. and the flow rates have been very good. Optilume is also one of the newer procedures available, and we are the first in the DMV area to have this available. No impact on sexual function. And the durability, right now there's data at the around the 2 to 4 year data showing only about a 4% retreatment rate. And we also do offer the old Roto-Rooter, the TURP, transurethral resection of the prostate procedure. This is done in the hospital. It uses an electrical loop that cauterizes, and you're able to scoop out the obstructing tissue. This is good for small and medium-sized glands. However, most cases, we're not really using this since we have much more updated versions of the Roto-Rooter, which with less side effects. The holmium laser enucleation of the prostate, you could think of this as separating the rind of the orange from the pulp. So all of our other procedures, we've remove tissue like the TURP, it removes tissue from the inside out. So you're scraping it until you get to the outside rind. This procedure is different where you're separating the rind directly. And so once you find that plane, you can carry it all around. And so you follow the natural anatomic planes to remove the prostate in its entirety. Well, let me clarify that. The transitional zone of the prostate where the blockage of urine is happening. We're not removing other parts of the prostate, like the peripheral zone where prostate cancer is more likely to occur. We're only removing the blocking portion of the prostatic urethra. And then after you remove this area, then we have a device called a morcellator that can chew up the prostate so that those pieces can be removed from the body. This has a longer operative time, anywhere from 2 to 4 hours, depending on how big your prostate is. And as we discussed earlier, about a 3% chance of incontinence. And usually you can count on having ejaculatory dysfunction issues after this. So we do offer clinical trials. And so while you kind of get the benefits of both having access to newer technologies and newer innovation in this BPH space, and also being compensated for that. So we're the first in the area to offer Optimum BPH and one of the highest volume centers across the US. And we're basically getting information showing that this procedure is safe and efficacious. The procedural costs are completely covered if you enroll in this trial, and patients also get a stipend for participating on top of having the cost of the procedure covered. The other trial we have is our Olympus trial. This is comparing the iTind device to the UroLift device. The UroLift device has good 5 to 7 year data. The iTind device is trying to get more data to compare head to head. And so patients are randomized to either the iTind or the UroLift. Again, both procedures will be compensated, whichever one you get randomized to. Patients will receive $1,000 at the time of randomization, $4,000 total for standard of care follow-up. And both devices, if have the same efficacy and safety. And for any of our trials, if patients don't feel comfortable or they want to remove themselves for any reason, there's no issue with that. The other thing about the trials is we would only, after doing the workup with the Eurocuff, the cystoscopy, and the transrectal ultrasound, if you're not a good candidate for those procedures, we will not have you enroll in those clinical trials. At the end of the day, we want to make sure that you get the proper treatment. and not just to get you in a clinical trial. Okay. Oftentimes, those two things do align. So it's been a big benefit to our patients to have this available and having some compensation for it. Okay, moving on to our next trial. This is aquablation in patients with prostate cancer. So typically when we think about aquablation, we're only talking about BPH. However, in this trial, we're trying to show assess safety and efficacy of aquablation in patients with BPH and low-grade prostate cancer. So instead of just removing the prostate tissue and the blocking portion of the prostate, called the transitional zone, we can also ablate tissue in the peripheral zone where prostate cancers typically are located. Uh, and patients afterwards will follow up with an MRI and prostate biopsy. Again, if there's any concerns about cancer control or whatnot, that always comes first. So I'm going to go over now just what aquablation is and go really in depth into it because again, this is one of our biggest workhorse for our BPH procedures. And their motto is BPH relief without compromise. So aquablation therapy, it's a robotic procedure that removes prostate tissue using the power of water or high pressure water jets. Um, Unlike the TURP, where you're using heat, and heat can cause issues with erectile dysfunction and whatnot, you're using a high pressure water jet instead, that you don't get that heat. Because to map out your prostate, we have a transrectal ultrasound probe that goes in your rectum. We map out your prostate, and then the robotic water jet will ablate that tissue. It's very precise. You get consistent and predictable results. And the size and shape of prostates, there really is no limitation there. And 0% of impact on erections or orgasm. It's about a 10% effect on ejaculatory issues, though, causing ejaculatory dysfunction. And then we discussed about the really low rate, less than 1% of incontinence. So we will use while you are asleep, this is about an hour-long procedure. We place an ultrasound probe in your rectum. We're able to see the water jet ablate the tissue in live time. That way we can make sure we're contouring your prostate as we want and we're not getting too shallow or too deep. Uh, So here's a picture of what we see on the image cystoscopy at 12 o'clock. That's our water jet on the left and right side of the blocking prostates. The middle image is just showing how the transrectal ultrasound is in the rectum. And then the water jet is through your penis going through your prostates. And the ultrasound image is what we go by. You know, we're mapping out exactly where your prostate is, how deep we want to go. So uh, all anatomy can be done this way. If you have a median lobe, we can map a median lobe. If we want, if every people's bladder necks or their lobes are in different locations, because we are able to map it out precisely, we're able to get very good results. And these four images are just showing four different types of prostates and how each of them can be treated. So, summarize why I choose aquablation. There's low rates of irreversible complications like incontinence and ejaculatory issues. You're gonna get a very consistent surgery given that we're using robotically controlled technology. And the durability of it, you know, we're going for like 10 to 15 years. And this is just showing how, a small prostate is like a grape size, kiwi size is medium, an orange is large, and then a big avocado can be extra large. And, we have prostates are 300 milliliters sometimes too. And despite that, you know, the TURP is good for small and medium. The holmium laser enucleation can be good for the large and extra large, but it's at the expense of, or the trade-off is that you can have higher rates of incontinence and ejaculatory issues. Aquablation uh, can do all these sizes. It is basically size independent. So for recovery after any resective BPH procedure, you'll wake up with a catheter. That catheter stays in for 1 day. You'll be discharged the same day from the hospital or our surgery center, and we'll have you come to our clinic the next morning for catheter removal. It's very normal to have some mild burning during the first few weeks, some intermittent blood, but after like 2 to 4 weeks, the blood resolves, and then you're back to your normal activities, typically or as early as 2 weeks or 4 weeks, depending on your recovery and your symptoms. Okay, so I'm at the end of our formal presentation, and I'll open it up to um, any questions. Let's see. I'll start from the top. So our first question was, with recent MRIs, the transrectal ultrasound still done? Yes. Um, so MRI is great. And more for prostate cancer, it is becoming almost standard of care to get prostate MRIs. However, insurance is not up to date on that. And so many insurance companies will require you to have a measurement of your prostate by transrectal ultrasound in order for insurance to pay for it. Even though you may already have an MRI, insurance-wise, to cover the procedure, you will still need a transrectal ultrasound. It's very silly. But clinically, is it necessary? Not necessarily. Our next question is aquablation similar to laser in principle, removing prostate material from the inside of the prostate? Yeah, so TURP, aquablation, and the laser enucleation of the prostate, all three are resective procedures. We're actually removing tissue rather than just stenting things open or making the channel bigger. We're actually removing tissue to make the channel bigger, and that's why you get more durability. So in the sense that they're all resective procedures, they're the same. However, the laser nucleation removes more tissue, but not everyone needs that much tissue to be removed to have good outcomes. And the downside of removing all that tissue is you get higher rates of incontinence and ejaculatory problems. Next question was, with PAE, prostatic artery embolization, when will maximum improvement be achieved? We typically say that it takes about 4 to 8 weeks to have peak improvement after the PAE. And so that's why we see people at the 4 month mark afterwards with the peeing Euro flow test to see objectively if the flow has gotten better and to reassess symptoms. Okay, and then the next question was, can PAE be repeated if the amount of change doesn't adequately address the symptoms? So from a technical standpoint, for sure, PAE can be repeated. Although I would be hesitant. Let's say you had your PAE 4 months ago and you're seeing me in clinic and you say, hey doc, I haven't noticed a single change. While we can repeat that procedure, I don't know if that would be the best option for you. At that point, we can talk about repeat minimally invasive procedures versus maybe just going forward with aquablation or a resective procedure. And then with PAE, what is the long-term follow-up and follow-up testing? So the way that our practice is run, we work very closely with our interventional radiologists, and just like any procedure, it's about experience. And so our interventional radiologists specialize in urology. They do 6 of the PAE procedures in a day or more. It takes them 30 minutes to 45 minutes. If you go to a less um, experienced proceduralist, it can take 2 to 3 hours. And because we're so well integrated and they're part of our system, the follow-up is very seamless where after your PA procedure, they'll have a 4-month follow-up with us. For any BPH procedure that you have, we'll be following you with repeat urine flow tests to make sure your flow is sustained. We'll be checking in with urinary symptoms. Later on, if you have any concerns about decreased flow, we can always repeat the cystoscopy and the ultrasound at that point, especially if you had like a minimally invasive procedure where we're not where the retreatment rates are higher. Someone said, is this for scheduling call? I'm not too sure what you mean by that. So if you can re-type the question more in another way, then I can try to answer it. And next question was, does the size of the penis matter in any of these procedures? The answer is no. The length of the penis or girth of the penis doesn't necessarily matter. What does matter is the size of the urethra, like to be able to accommodate our tools, our scopes. Um, and so typically urethras are pretty pliable, so they can accommodate our scopes. If they don't, we can passively try to stretch them out so that our scopes can fit, but rarely is it an issue where we can't do the procedure because the urethra can't accommodate our scopes. Do you use nitrous with cystoscopy and can you drive afterwards? So I would say a majority of the time, um, we're able to do, depending on what location you're at, we offer cystoscopies and transrectal ultrasounds just under local anesthesia with numbing jelly in your penis, and you can drive yourself. However, if you're being seen at our Alexandria clinic, all of our procedures have been are being done right across the bridge in National Harbor. Uh, and that's still over there. You can do it just with local anesthesia, the numbing jelly, and drive yourself. But if you've had the cystoscopy in the past, or you know that you don't tolerate that sort of discomfort well, or you just want to have a more relaxing experience, the nitrous is available at our surgery center. If you do have nitrous, you cannot drive yourself. Um, the next comment was uh, concern about PAE spreading prostate cancer. And so there's been plenty of research with PAE, and as far as spreading prostate cancer, there isn't uh, really any substantial evidence to show that. So I would not have that deter people from doing that. You know, what can happen sometimes is we get a PSA on everyone during this BPH workup. And even though the PSA is low, even though the transrectal ultrasound or MRI may be negative, it's still possible to have cancer. And if you do PAE on someone who has cancer, it doesn't change their cancer at all. It's just maybe it's picked up later on. And so it does not spread cancer. Can many of these procedures also help improve ED in addition to urination? It can. So, I don't ever advertise. I will say, doing a BPH procedure, I never say your ED will get better, but in some patients it may. But that is not the selling point of the procedure. If it happens, it's just a fortuitous uh, plus to doing the procedure. The next question was about medications. Taking finasteride now, does it worsen prostate cancer? So, taking finasteride, the research is not as clear. So it does not increase the chances of prostate cancer. However, it may increase when the prostate cancer is detected. It may increase the grade. It may be a higher grade prostate cancer that is diagnosed. Um, Finasteride, when you take it, it can shrink the prostate and it artificially decreases your PSA by 50%. So anyone who's on finasteride, if you have a PSA that's 3, in actuality, if you stop taking your finasteride, you can adjust that to being closer to 6. And so, that 4 cutoff that we use for concern about prostate cancer, we have to take that into consideration when someone is on finasteride. But for prostate cancer workup, no one thing is used to determine your prostate cancer risk. We combine prostate MRI, the velocity of how quickly your PSA is rising, something called a PSA density meaning per volume is the PSA more dense. So if you had a huge prostate and your PSA was 6 versus an itty bitty prostate and your PSA is 6, I'm more concerned that the person with the itty bitty prostate with the PSA 6 has prostate cancer because their PSA density is higher. Because normal prostate tissue makes PSA, but prostate cancer cells make PSA at a higher rate. Um, Okay, the next question is, doesn't aquablation spread cancer? So the answer is no. There is no evidence showing that TURP or aquablation or any BPH procedure spreads cancer. If you already have cancer there, okay, not often, it's not uncommon that when you do a resective procedure, because even for aquablation, after we ablate the tissue with water, we do get some focal cautery to stop any bleeding. And we also remove a little bit of tissue and we make sure that tissue is benign. So some people already have prostate cancer, and when we resect tissue, we're able to see that they have prostate cancer. But typically, the way we diagnose prostate cancer is by doing a prostate biopsy of the peripheral zone. But let's say, we resect tissue and, patients ask me, hey, doc, aren't you concerned that you're seeding this prostate cancer into the bladder? And theoretically, that does make a lot of sense. But in actuality, when we look at the research, that's not how prostate cancer spreads. Prostate cancer affects glandular tissue. And one, your bladder itself has an impermeable layer called the urothelium that it's not affected by that. So the answer is it does not spread prostate cancer. When you do aquablation, can you send the removed tissues for cancer? Exactly. You can send it for cancer screening, but the second part of the question was, then can you eliminate a biopsy? And no. So if your prostate's like this, your urethra is right here, we're removing the prostate tissue around the urethra, but we leave a rim of peripheral tissue called the peripheral zone, and that's mostly where prostate tissue is located. So even after you have a positive tissue sampling from an aquablation or a TURP or even a HOLEP, then we need to biopsy you appropriately because the peripheral zone may have more aggressive cancer than what's in your transitional zone. And so we have to be very thorough about that. Okay. Next question is cystoscopy done prior to scheduling a PAE? Yes. So the standard workup for our BPH because we offer so many different procedures, we need to tailor it to your body and your preferences. So everyone gets the same workup. Uh, you have the Eurocuff test to measure your flow and your bladder pressures to see if you have a functional blockage problem. You get the cystoscopy to look at the shape of your prostate, if it's just your lateral lobes or if you have that median lobe, and also to look inside the bladder to see your bladder health, to see if there's already bladder damage. And then lastly is the transrectal ultrasound to get an accurate size. So after you do those three tests, then we can recommend PAE if you and discuss whether you be a good candidate for that. And the thing, and I didn't make this point clear before. You can have two identical people, identical size, shape of their prostates, bladder health, Eurocuff tests. But if one person wants a minimally invasive procedure and the other person wants a resective procedure, they're gonna get different treatments. So it's not just the objective measures we have. A lot of it, we're gonna be working together as a team to decide what's the best treatment. And at the end of the day, once you know the risks and benefits, whatever choice we make together, that is the correct choice. Okay, our next question is, how painful is a cystoscopy? Uh, it really depends. Everyone's tolerance is a little bit different. Uh, I have some men who they're like, oh, that was it, and other men who are really uncomfortable during the procedure. And for those people, we in the future we may have them do it under nitrous or uh, do other relaxation techniques for their pelvis to make it easier. With all my cystoscopies, I tell patients to, take nice, slow, deep breaths, to wiggle their toes, even to whistle or purse their lips, because by doing so, it relaxes the pelvis. And I also make it clear that patients shouldn't tighten up their abs because it clamps down on the urethra, and that trying to advance the scope through a clamped down urethra, that causes pain. And so it can be really subjective. How do we discontinue Proscar and Uroxetrol in conjunction with PAE or Aqua or iTind? Okay, so for Aqua, any BPH med you're on, you stop it the next day. I don't need you to continue that. For PAE, ideally, depending on how severe your symptoms are, I think everyone should get a trial of discontinuing their medications. Uh, I would first stop the finasteride, and then maybe after another month stop the alfuzosin, tamsulosin, uroxetrol, because the finasteride takes about 6 months to go peak effect. It also takes about 6 months to lose its effect, whereas the other alpha blockers work immediately within a couple of days. And so PAE for the first month, you may not notice any improvement. So I would not start peeling back medications until you're 4 to 8 weeks through it. And then for iTind, um, yeah, would consider stopping the alpha blockers and finasteride uh, like a week or two afterwards when all the inflammation and swelling has gone down. And then if you feel more uncomfortable, then you may have to restart an alpha blocker. But hopefully at that point, um, you'll be able to have more benefit than you did before the procedure. In a perfect world, the whole point of doing a minimally invasive procedure would be to get you off meds so you're not on one daily. And so if we don't accomplish that goal and that was one of your priorities, then we can talk about doing a more definitive procedure, a resective procedure. And then will you send us a copy of the presentation? Yeah, I'll find a way to disseminate this information. Okay, may I ask how many aquablation I've done personally? So in our practice, I'll start with the most senior, uh, Dr. Inder Singh. He's done, I think he's approaching like 900. He started back in 2018. Uh, John Klein. So there's four aquablation specialists in our practice. Um, it's Dr. Singh, Dr. John Klein, Dr. Shanmar Madi, and myself, Dr. Lim. Uh, in seniority, Dr. Singh is definitely the most senior. I'm definitely the most junior. Under my belt, I probably have around 100. The difference between my training and my senior partners is when I trained at Georgetown, Georgetown was learning how to do this aqua ablation, and then so I was already trained in residency to do this procedure, and so when I came and practice here, I was already up and running. Does small 0.5 centimeter kidney stone condition impact prostate treatment options? Kidney stones are completely separate. It does not preclude you from doing any prostate treatments. Um, so it should be unrelated. And let's see. When we take tamsulosin finasteride to control BPH and prostate cancer, what are the side effects to male sexual activities or performance? Okay, so the reason why um, this is a shift in a paradigm shift on how we treat BPH. So older generations of urologists, back when there was only the rotor-rooter to really treat BPH, more people were on medications. So everyone was on tamsulosin and finasteride. And it wasn't until you were truly unhappy that your symptoms were not treated well that urologist may have offered you a TURP or a resective procedure. But with this boom in innovation and all of these different minimally invasive options, I would say the paradigm shift has been we need to focus on preserving bladder health. So, also, medications are not without side effects. Tamsulosin, the most common side effect is dizziness, lightheadedness, and especially in our elderly patients, more senior patients, that dizziness, it only takes one fall to hit your head to break your hip that is life changing. Also, there's retrograde ejaculation issues with finasteride. There are issues with erectile dysfunction, breast tenderness. It affects hormones, so that's why it shrinks your prostate. The other benefit, other than shrinking your prostate, is that it can help with hair growth. But you know, I would in my personal practice, unless you truly do not want a procedure, unless you are really have other medical issues precluding you from doing a procedure, I do not like having people stay on medications, especially if you're early on the BPH spectrum, age spectrum, and you're starting medications at 50. Like you're going to be on this for the rest of your life, and eventually it may stop working. Like we can do a procedure and get you off of a medication or two by actually fixing the problem. Um, and I think that's all I had for here. So I've been talking for a bit. I really appreciate everyone taking the time this evening to listen and to get more education about BPH. BPH is an area that I'm really passionate about, and at Potomac Urology, we have such a comprehensive, standardized pathway to treat patients that you will be in good hands. I can promise you that. Okay, let's see. One last question. What is the PSA level that needs the practice? Um, PSA, we just screen to make sure there's no concern for prostate cancer. We always, if there is concern for prostate cancer, we address that first, and then once we make sure the MRI is fine or the prostate biopsy is fine, then we go back to focusing on BPH. Okay, everyone. I really appreciate you guys taking out the time. If there are any questions, please contact our offices. Hopefully, this gives you some more information and motivates you guys to, if you are on the fence about doing a procedure, that you don't have to continue living the way that you're living. There are very safe options. Even our more maximally invasive procedures like aquablation are still very safe. It's a same-day procedure. Um, so it was great chatting with all of you. One last plug that I will say is if you guys, we do have a YouTube channel that goes over aquablation more in depth and all of our BPH procedure, really all of our procedures and other information about urology. So you can find us at the Potomac Urology Center. And if you subscribe, you'll be updated with all our latest news and everything. Okay, have a good night.